about the difference between plasma and blood. So blood is plasma plus cells and protein. If you centrifuge blood, you will get something like what's shown on the screen here. About 55% of blood is plasma. There's a tiny bit that is made up of leukocytes and platelets, and then about 45% is erythrocytes. For this reason, the renal blood flow is greater than the renal plasma flow, and there are separate calculations to convert a renal plasma flow, like we determined with PAH, into a renal blood flow that includes the flow of the red blood cells. The way that renal blood flow is determined from renal plasma flow is by using the hematocrit. Blood, as I told you on the last slide, is plasma plus cells and proteins, and the percentage of blood that is cells and proteins is roughly equal to the hematocrit. And the hematocrit is an easily obtainable number in clinical practice. So the math works out such that the renal plasma flow is renal blood flow times 1 minus hematocrit. So for example, if we knew that renal blood flow were 10 cc's a minute, and we knew that 40% of that blood was cells and proteins, that's the hematocrit, that means 60% of the renal blood flow must be plasma. Therefore, the renal plasma flow is the 10 cc's a minute times 1 minus 0.4 or 0.6, which works out to 6 cc's a minute. Another way we can rearrange this equation is to say that the renal blood flow is equal to the renal plasma flow divided by 1 minus the hematocrit. So for example, if we knew the renal plasma flow from an experiment using para-aminohippuric acid, and we also knew the hematocrit, we could then calculate the renal blood flow. An example of this calculation is shown on this slide. If we knew the renal plasma flow were 1 liter a minute and the hematocrit was 40%, then the renal blood flow is 1 over 1 minus the hematocrit, or 1 over 0.6, which is 1.6 liters per minute. And on your exams, you're sometimes asked to calculate not just the renal plasma flow, but the renal blood flow, so you have to know how to do this using the hematocrit. So back to our slide, just to summarize everything we've talked about. We talked about how you can measure the GFR, which is the fluid that crosses the glomeruli, by using either inulin or creatinine and determining the clearance for those substances. We talked about how you can determine the renal plasma flow, which is the fluid flowing into all the glomeruli, by using the clearance of PAH. And we've also talked about how you can measure the urine flow, the fluid out of the kidneys, experimentally by asking a patient to collect their urine over 24 hours. And just to continue our review of everything we've talked about, the filtration fraction is how much plasma to the kidneys gets filtered. It's equal to the GFR over the renal plasma flow. Normal is about 20%. We also talked about the filtered load for a given substance. This is how much of a substance gets filtered. It's equal to the plasma concentration times the GFR, and this is the amount of substance X delivered to the proximal tubule by crossing through the glomerulus. So basically what we've done is taken these measured variables like urine flow, plasma concentration, and urine concentration, and used them to determine some other more helpful variables in establishing how healthy the kidneys are. These are variables like clearance and plasma flow and GFR and filtration fraction. And then once again, inulin clearance or creatinine is used to measure GFR, and PAH clearance is used to measure renal plasma flow. Let's talk about the effects of prostaglandins and NSAIDs on renal physiology variables. Prostaglandins are signaling molecules synthesized by many cells in the body, and in the kidneys, prostaglandins are used to dilate the afferent arteriole and increase the renal plasma flow. NSAIDs are non-steroidal anti-inflammatory drugs like ibuprofen, and they block the production of prostaglandins. In the kidneys, this will lead to afferent arterial vasoconstriction. So what's going to happen is there's going to be less plasma flowing into the kidneys, so the renal plasma flow will fall. Because less plasma goes into the kidneys, there will be less filtered at the glomeruli, and the GFR will fall. The filtration fraction, like I told you earlier, is equal to the GFR divided by the renal plasma flow. And because both of these variables decrease in the setting of NSAIDs, you will see no change in the filtration fraction. And they'd like you to know these effects for your boards. Clinically, in patients who are healthy, this has no important consequences. However, in patients with chronic kidney or heart disease, this can lead to acute renal failure or retention of sodium in water and acute heart failure. And for that reason, NSAIDs are avoided in patients with heart failure and renal failure. ACE inhibitors also have important effects on renal physiology. ACE inhibitors are drugs used in hypertension and heart failure, and they block the synthesis of angiotensin II. And angiotensin II's normal role is to constrict most blood vessels in the body, but in particular, angiotensin II preferentially constricts the efferent arteriole. So if you give an ACE inhibitor, you will dilate the efferent arteriole. So what will happen here? Well, let's imagine that we have a glomerulus. This is the efferent arteriole over here. If we dilate this afferent arteriole because we administer an ACE inhibitor, blood is going to rush out of the glomeruli. This is going to increase the renal plasma flow, but because we have more blood exiting the glomeruli, less will be filtered into the nephrons and the GFR will fall. This means that the filtration fraction is going to fall because remember, the filtration fraction is the GFR as the numerator, the renal plasma flow as the denominator, and since the denominator is going up and the numerator is going down, we see a fall in the filtration fraction. They'd like you to know these effects for step 1 of your boards. Now let's talk about secretion and absorption. There are 3 factors that determine how much of a solute is excreted in the urine. The first is how much is filtered at the glomerulus. Obviously, if you filter more of a solute like sodium, then potentially more will go out in the urine. The second factor that determines excretion is the secretion rate. So some solutes are secreted by tubule cells, and this will lead to more going out in the urine. The final factor is absorption. So some solutes like sodium and potassium can be absorbed by the kidneys. So the more that is absorbed, the less will go out in the urine. So it's the sum of these effects, how much is filtered, how much is secreted, and how much is absorbed, that determine how much will go out in the urine. So for example, let's imagine that we know the GFR, which is the fluid that crosses the glomerulus, and then we calculate the filtered load of a substance. For example, let's suppose it's sodium. That will be equal to the GFR times the plasma concentration of sodium. We can then calculate the amount of sodium that goes out. If we know the urine flow, which is the fluid out of the kidney, and we know the urinary concentration of that solute, like sodium, we can determine the excretion rate. What if the filtered load doesn't equal the excretion rate? This must mean that there is some secretion or absorption that is modifying the amount of that substance going out, such that the amount going out is not the same as the amount filtered. And this is the effects of secretion and absorption by the nephron. So just to summarize, the amount of a substance excreted is equal to the amount filtered minus any that is reabsorbed plus any that is secreted. The amount filtered we can determine from the filtered load. That's the GFR times the plasma concentration. The amount excreted is the urine flow rate V times the urinary concentration. So if we take the difference between these two, that tells us how much reabsorption or secretion is going on. So for example, suppose that 10 milligrams of X per minute are filtered, but 20 milligrams of X per minute are excreted. We're excreting more than we're filtering, so an additional 10 milligrams per minute must have been excreted. So anytime the amount filtered is equal to the amount excreted, that means there's no net secretion or reabsorption. If the amount filtered is less than the amount excreted, then some must have been secreted by the nephron. If the amount filtered is more than the amount excreted, then some must have been reabsorbed. So for example, if for a particular substance 100 milligrams a minute is filtered and 120 is excreted, an additional 20 milligrams per minute must have been secreted. Example 2, suppose that 100 milligrams per minute are filtered, 80 milligrams per minute are excreted, then 20 milligrams per minute must have been reabsorbed. These are important concepts for you to understand. I'm going through them step by step to make them very clear. We can also gain some insights into secretion or absorption of a particular solute by looking at the clearance of a solute. So for example, if the clearance of solute X is equal to the GFR, then there must be no net secretion or reabsorption. And we talked earlier about how this is the case for inulin. In the case of inulin, what we have is a situation where the clearance is equal to the GFR, and that's why we use inulin to measure the GFR. If the GFR is less than the clearance, then there must be secretion of that solute. So for example, if we're filtering so much of a substance, but we're actually clearing more of that substance, then some secretion must be going on in the tubules. The opposite is also true. If the GFR is more than the clearance, then there must be some resorption. So for example, assume the GFR is 100 milliliters per minute, but the clearance of a solute is 120 milliliters per minute. Then an additional 20 milliliters per minute must be getting cleared by secretion. The converse is also true. If the GFR is 100 milliliters per minute and the clearance of X is 80 milliliters per minute, then an additional 20 milliliters per minute must be uncleared or reabsorbed by the nephron. Now let's talk about intake and output of solutes. We talked earlier about how the excretion rate of any solute is equal to the urine flow rate times the concentration of that solute X in the urine. And you should know that this excretion rate for any solute has to equal the amount that the body takes in every day. For example, you have to excrete the daily load of sodium that you take in your diet. The same is true of potassium and many other substances. The amount of any substance in must equal the amount out. Where this gets confusing, especially at the medical student level, is when an insult occurs, like renal failure or diarrhea, and you're asked what happens to the excretion rate. When one of these insults occurs, there's a transient imbalance that alters plasma levels, but then steady state quickly returns, such that if you're eating 10 grams a day of salt, for example, you're still excreting 10 grams a day. And this is something you have to understand. So for example, if something happens to the kidneys that impairs their ability to excrete sodium, eventually a new steady state will return where the amount of sodium being excreted is equal to the amount coming in. If it does not, you will die. So the kidneys modify their excretion rate of solutes so that they continue to excrete what is taken in. This happens in healthy states and in disease states, and this is one of the most confusing topics in renal physiology. To drill down on this further, let's talk about how different solutes are handled by the body in the setting of renal failure. Regulated solutes include solutes like sodium and potassium. The levels of sodium and potassium are tightly controlled by the body. ADH controls sodium levels, aldosterone controls potassium levels. This means that in the setting of mild to moderate renal failure, there's no concentration change. If your body allowed sodium and potassium levels to rise in mild to moderate renal failure, you could die from volume depletion, because in that setting your GFR falls and you would get hypernatremic or hyperkalemic. But that does not happen because these solutes have regulated levels so that they stay normal as long as you still have some kidney function left. Other solutes like creatinine and urea are unregulated, and their plasma level rises in the setting of renal failure. So for example, in a patient with hemorrhage who has a fall in GFR, that patient's creatinine and urea level will rise because these solutes are not regulated by the body. To make this more clear, let's build a table together, and let's start by considering a patient who has a normal GFR of 100. That patient will have values for potassium, sodium, and urea in the plasma that are normal as shown on the table. Now let's imagine that patient develops some type of insult and the GFR falls by half to a level of 50. Well, that patient will still have a normal plasma level of potassium and sodium because these are regulated solutes and the body does not allow them to rise in the setting of a fall in GFR. Urea, however, is unregulated, so its level will rise in the plasma when the GFR falls. This has consequences in terms of the filtered load. Remember, the filtered load is the GFR times the plasma concentration. So the filtered load for potassium and sodium is going to fall. That's because there's less GFR and the plasma concentration has not changed. However, the filtered load for urea is exactly the same. The GFR fell by half and the urea level doubled. In other words, the only way the kidneys can eliminate urea is through filtration, so they must maintain the filtered load. Potassium and sodium, the kidneys can secrete these substances or reabsorb less, therefore the filtered load is allowed to fall and the kidneys will manipulate the amount of secretion or reabsorption. Here's the tricky part though. The daily excretion rate of potassium, sodium, and urea is always the same. It has to equal the intake. You must excrete all the potassium and sodium in your diet, and you must excrete the urea produced by metabolism. So even though the GFR has fallen by half, the excretion rate has not changed. That's a very tricky concept. Make sure you understand that. And what about the fractional excretion? The fractional excretion is the excretion rate divided by the filtered load. The excretion rate has not changed and the filtered load has fallen for potassium and sodium. Therefore, the fractional excretion has gone up. In other words, the kidneys are excreting much more of what they filter because they are filtering less. In the case of urea, there's been no change in excretion rate, no change in filter load, so the fractional excretion has not changed. Make sure you go through this carefully and understand everything on this slide. It's very high yield. I'll finish this video by going through a couple sample renal physiology problems of the type you're likely to see on your board exams. A patient has a urine output of 4,800 cc's per day or 200 cc's per hour. Plasma concentration of substance X is 4 milligrams per deciliter. Urine concentration of X is 8 milligrams per deciliter. What is the clearance of substance X? So this is a basic problem where you're simply asked to use the clearance equation and plug these values in. So they tell us that the urine concentration of X is 8. They tell us that the volume of urine flow is 200 an hour. And they tell us the plasma concentration is 4. So if we plug all these numbers in, the clearance for substance X is 400 cc's per hour. Question 2, a patient is infused with inulin. At steady state, plasma concentration of inulin is 3 and urine concentration is 6. If the GFR is 200, what is the urine flow rate? So we have to remember that GFR is equal to the clearance of inulin. That means that we already know the clearance of inulin. What they want us to figure out is V, the volume flow rate of urine. So we just plug in the numbers here. We solve for V. It's equal to GFR times the plasma inulin concentration divided by the urinary inulin concentration. If we plug in the numbers, that's 200 times 3 over 6. Therefore, the volume flow rate of urine must be 100 milliliters per hour. Question 3, a patient is infused with PAH. At steady state, plasma concentration is 5 and urine concentration is 10. If the urine flow rate is 200